Hey, what's up, everyone? Welcome back to Shock Doc Medical. I'm Dr. Raad, and today we're diving deep into something that might seem ordinary at first, but could totally change how you see those pesky rashes and swellings. Have you ever gotten hives out of nowhere, or noticed weird, deep swellings around your lips or eyes, and wondered what's really going on? Today, we're talking about allergy histories, specifically everything from urticaria and angioedema to contact dermatitis. Trust me, by the end of this episode, you'll know exactly what to look out for and even how some treatments are dosed, so stick around. All right, so here's the deal. When we talk about allergies, especially the kind we call type 1 hypersensitivity reactions, we're dealing with some pretty immediate, sometimes explosive responses. You've got urticaria, better known as hives or welts, which are these raised, smooth, pink or red bumps that show up on your skin. They're essentially a sign of second-degree dermal edema, meaning there's fluid buildup in the skin. And let me tell you, these wheals are not just a cosmetic issue. They're usually super itchy and can pop up and vanish within 24 hours, sometimes stretching to 48 hours at the absolute worst. And get this, they tend to fade completely, leaving your skin looking totally normal again. Ever had that happen? That's your body's way of saying, I got this, in its own way. Now, acute urticaria can be triggered by pretty obvious culprits like drugs, think penicillin, or foods like peanuts or fish. If you've ever had a bad reaction after eating something or taking a certain antibiotic, you know exactly what I'm talking about. But here's the kicker. Chronic urticaria is a whole different beast. Most of the time, you can't really pinpoint the exact trigger, and that makes it a real headache for both patients and docs. Oh, and let's not forget physical urticarias. These are triggered by things like firm pressure on the skin, heat, cold, sun exposure, or even exercise. So whether it's that tight shirt or a day at the beach, your body might decide to throw a little hissy fit in the form of hives. Now, if you think hives are wild, wait till you hear about angioedema. This isn't your run-of-the-mill skin reaction. Angioedema involves swelling in the deep layers of the skin, including the mucosal tissues. So we're talking about your lips, tongue, and even your larynx, which, if it swells up, can be pretty dangerous. People often describe it as sudden, deep, tender swellings, sometimes affecting the hands, feet, and even genitals. And if you ever feel a weird puffiness around your eyes or lips, or have trouble swallowing or breathing, that's a red flag. A unique twist here is in patients with C1 esterase inhibitor deficiency. These folks might experience angioedema without any hives at all. Things like dental procedures or even vaginal pressure during intercourse can trigger attacks in these patients. And sometimes they might even have gastrointestinal symptoms like vomiting or abdominal pain. Imagine that, a stomachache that's actually a sign of a much bigger immune issue. Now, if you're a healthcare provider or even just a curious mind trying to understand what's happening, the history you take is crucial. Let's break down some of the key points you need to cover. For urticaria, triggers, ask, what set this off? Did you have penicillin, peanuts, or maybe some fish? Appearance and behavior. Check if the wheals are raised, pink papules or plaques that are smooth and itchy. They should blanch with light pressure. That's your erythema in action. Duration and distribution. Most wheals last less than 24 hours, maybe 48 at most. They tend to come and go in different places and then fade, leaving no trace. Dermographism. Try rubbing the skin. Does it wheal? That's a telltale sign. For angioedema, triggers. Look into any potential triggers like dental work or sexual activity, especially in those with suspected C1 esterase inhibitor deficiency. Symptoms. Ask if they've experienced sudden deep swellings on their hands, feet, or genitals. If they've had swelling in the lips, tongue, or larynx. If there's any puffiness around the eyes, or if they've had trouble swallowing or breathing. Also, listen for any reports of stridor, wheezing, or even GI issues like vomiting or abdominal pain. For contact dermatitis, history and exposure, you want to find out what products the patient has been using. This could be something they've been in contact with for a long time, maybe a new detergent or cosmetic. Symptoms and appearance. Is the skin red, scaly, or blistering? Does it itch? Occupations and hobbies. What does the patient do? Do they work with chemicals, do a lot of wet work, or have any hobbies that involve exposure to irritants? Timing. Does the rash get better on weekends or holidays? Product use. What are they using on their skin for washing or moisturizing, and for how long? Atopy is the patient atopic because irritant contact dermatitis is more common in people with dry, sensitive skin. Okay, now that we've got the history down, let's talk treatments, because I know a lot of you are wondering, what do I do if I or someone I know is dealing with these issues? Let's break it down. For acute urticaria, antihistamines. The first line of defense here is second-generation H1 antihistamines. Cetirizine. Typically, we use 10 milligrams once daily for adults. For kids, it's generally around 0.25 to 0.5 milligrams per kg of body weight, up to a maximum of 10 milligrams per day. Loratadine, often 10 milligrams once daily for adults. Fexofenadine, usually 180 milligrams once daily. Corticosteroids. In more severe cases, a short course of oral corticosteroids like prednisolone might be considered, usually around 20 to 50 milligrams daily for 3 to 5 days, depending on the severity. For angioedema, acute management. If there's any sign of airway compromise, immediate treatment with epinephrine is crucial. For adults, that's typically 0.3 milligrams intramuscularly, and for children, it's about 0.01 milligrams per kilograms. Supportive care. Along with epinephrine, antihistamines and corticosteroids can be used to control the reaction. For contact dermatitis, avoidance. First and foremost, identify and avoid the offending agent. Topical treatments. Mild cases, topical hydrocortisone 1% cream applied twice daily can help calm things down. Moderate to severe cases, you might step it up to a mid-potency steroid like triamcinolone acetonide 0.1% cream. Emollients. Keeping the skin moisturized is key. Regular use of fragrance-free moisturizers helps restore the skin barrier. Patch testing. For allergic contact dermatitis, patch testing is the investigation of choice to pin down the specific allergen. And here's a cool twist. Sometimes people with long-standing dermatitis might develop a secondary allergic contact dermatitis because of the various topical medicaments or over-the-counter products they've been using. So, it's not just about one reaction. It could be a compounding problem that needs a comprehensive look at their skincare routine. Listen, folks, understanding the history behind these allergic reactions isn't just academic. It has real-world impact. Whether you're a patient trying to figure out why those hives keep coming back, or a provider trying to nail down a diagnosis, knowing exactly what questions to ask and what signs to look for is critical. And sometimes it's the little details. The fact that wheals last less than 24 hours, or that a rash improves on weekends, that can make all the difference. I remember a case where a patient had been dealing with chronic hives for months. No one could pinpoint the trigger until we really dug into their history. And guess what? It turned out to be a cosmetic product they'd been using for years without even thinking twice. That's why getting that detailed history is so important. All right, so to recap, urticaria can pop up acutely with identifiable triggers like drugs or food, or it can be chronic and elusive. Angioedema is a deeper, sometimes more dangerous swelling that can occur with or without hives, especially in conditions like C1 esterase inhibitor deficiency. Contact dermatitis comes in two flavors, irritant and allergic, with a lot to unpack in terms of exposure history and treatment. And remember, treatments are available, from antihistamines like cetirizine 10 milligrams daily to topical steroids like hydrocortisone 1% cream. But of course, nothing beats a thorough history and understanding your own body's reactions. If you're dealing with any of these issues, talk to your healthcare provider about getting a detailed workup, including things like prick testing for acute urticaria or patch testing for contact dermatitis. And if you're ever in a pinch with angioedema, especially with airway issues, don't hesitate to use epinephrine. I hope today's deep dive helped shed some light on what might seem like a confusing and complex topic. Drop your thoughts and questions in the comments below. Let's get a conversation going, because we're all in this together. Before I sign off, if you found value in today's episode, hit that like button, subscribe to Shock Doc Medical, and share this podcast with anyone who might benefit from it. Next week, we're going to explore another groundbreaking topic that could literally change the way we approach everyday health issues. Until then, stay curious, stay informed, and keep questioning the world of medicine. This is Dr. Raad on Shock Doc Medical, signing off. Catch you later.